All right, good afternoon. We appreciate everyone joining us today, and we're very excited to have J.R. DeFeo and Michael Alterman with us, who will present their expert knowledge on effectively utilize A&I in an affordable manner. This webinar is being recorded, and we will add it to the IRHA resources page for all our members to view. Just a few quick housekeeping items before we begin. Again, as I mentioned, we're recording today's session, and it will be available within a week once the recording is processed. If at any point during this presentation you want to ask a question, please use the Q&A function or click the raise your hand button and we'll allow you to speak. This function is accessible by hovering your mouse over the screen. It should pop up either at the top or at the bottom of your screen, just depending on what view mode you're in. And I'll keep an eye out for these questions and we'll moderate for the presenters so they don't have to check them during the presentation. So without further ado, I will now turn it over so you guys can begin your presentation.
Great. Thank you, Caroline. Welcome, everybody, and thanks for taking some time out of your day to listen to us speak about machine learning and AI in healthcare. My name is J.R. DeFeo. I've been in healthcare for, I guess, 25 plus years. And then also with me is Michael Alterman. We're co-founders of Foundation DX. Michael has been in healthcare for a little longer than me and has been on the engineering and data scientist side of the house. I've worked in the provider side as well in the beginning of my career in healthcare. So looking forward to having the presentation. As Caroline mentioned, if you have questions along, raise your hand or just ask them as we go, because sometimes people tend to forget what they are, and then as we move on, might not get to them. So the agenda and learning objectives for today, and we're kind of stick through these and hopefully answer your questions as we go along. So how do other industries utilize AI? And really, how can they be transferred to healthcare? And as those of you that are on the call with us may realize that healthcare, unfortunately, from a technology perspective, other than clinical applications, sometimes is a bit behind other industries. And the fortunate thing about that is you can take what other industries are doing and hopefully that lends itself in use cases within healthcare. The other thing we're going to look at is how can it positively impact healthcare providers such as yourselves, and specifically within rural settings. And then we're going to provide some examples and some different tools and technologies and ways of deploying AI. All along the way, we're going to do a couple of different things. One, to try to keep it fairly simple and not get too academic or too technical, but rather make it more about how you could use AI or machine learning in your settings, some of which are examples of use cases or projects that we've undertaken. Others are ones that we would like to undertake or make sense in your setting. But in all these cases, what we're going to go about and talk about are things that should be affordable, use cases that could be done with data that is available to you, and not something that's going to cause, again, a lot of time or a lot of money to solve. So now for the million-dollar question, what is AI? I'm sure all of you that are on with us right now have heard of it, obviously. And if you talk to 5 different people, you'd probably get 5 different answers as to what is AI, not what does it stand for, but rather what does it do? And here you can kind of see what looks to be somewhat of an eye chart with a bunch of different definitions as to what AI is. For purposes of this presentation, which we can distribute even after the presentation on PDF form, even before the recording is set out, if you so like. Our view of it is the following, especially as it relates to providers such as yourselves, would be use existing data, mine that existing data, even if it's large amounts of data, to find things that would be very difficult for a human or a group of humans to find. So those could be anomalies, that could be areas to concentrate on from a cost perspective. A lot of these things we'll go through, but again, what we're looking at is ways to tackle and use AI that are easy to use, relatively easy to use, and affordable to deploy, and using existing data that you should have within your EHR or with other databases that you have access to. Michael, you mind taking this slide?
Sure. So this is an important representation of the type of work that we do, and in general, the purpose of adding AI into a healthcare process. And when I say process, I mean multiple different things relating to healthcare, such as an episode of care, the episode of a hip replacement, from pain to surgery to recovery to rehab, all of that. It could be recovery from a heart attack. It could be managing a diabetes marker. It can be managing high blood pressure. So a process is sort of like an episode of care over time. That's influenced by the patient and medication and external and factors and so forth. So we can take a process that we're interested in. Again, it could be at the patient level, it could be at the population level, it could be at a disease level. It doesn't matter, but it's a process where you have inputs and outputs. And so we all have inputs: our daily lives, our medications, our lifestyle, our activities, supplements, all of it. And then we have outcomes. We go to the physician periodically, over-examine, we get our blood work done, we have symptoms or we don't have symptoms. Those are sort of outcomes. And we can treat those outcomes as data. And we can feed that data into, like, step one, into an artificial intelligence algorithm. And that data might indicate like a metric for managing blood glucose. We want to keep it low for a diabetic patient. So we know what it is because it comes out of the lab, and we know where we want it to be because that's determined by guidelines. I put that in quote because guidelines are changing, or they will be changing relating to that. And the machine will actually learn what are the factors associated with the patient's lifestyle, medications, demographics that seem to have an impact on their measured outcome. Let's say, blood glucose level or hemoglobin A1C. And once we see what those factors are, I mean, it could be many things. It could be medications, it could be lifestyle, it could be the diet, it could be the height, the weight, the BMI, and so forth, other medications. We don't know what it is because many factors could affect blood glucose, including other medications and so forth, and certainly diet. The interventions that we find or that we design can be based on what we've learned to be the factors causing the difference between the measured and the desired outcome. And this example may be hemoglobin A1C. So this could be very personalized. And because the machine runs very quickly on data, and we can design the interventions quickly based on what we've learned, we can apply it back to the process, change the medications, make dietary recommendations, and so forth. Monitor more frequently, whatever needs to be done. So this can close the loop rather quickly. So because there's a machine involved doing the hard number crunching. So it can speed the process of quality improvement, and it can shift the work burden from what has been in the past to try to figure out what to do next based on one or two parameters, hemoglobin A1C that's increased, insulin or diabetic medication, to actually understanding the other factors that could be causing the problem versus just upping the dosage of medication. So this is the sort of the promise of AI. And so this process of feedback, as you see here, can be applied to almost any sort of problem, whether that's a clinical outcome or a cost outcome, and so forth. Okay, JR, next. Okay, so AI outside of healthcare, and many of you are familiar with some of this already. Certainly, it's been used in the banking industry for fraud detection for a while, and it's used in retail and e-commerce. AI is used to personalize shopping experiences, and those of us that have had experience with, Amazon and so forth, can see that it certainly knows how to suggest something we may be interested in. Clearly, that's AI. And how does that work? It's supervised learning because it's learning what we're interested in and what we buy, and it looks at the pattern of things. We like red clothes or different types of items that certain size clothes or whatever we purchase. And it looks through its library and sees, hey, there's some similarities with these other products. Let's offer those. So that's AI. Manufacturing certainly uses AI today. Transportation to optimize route planning when the vehicles have to go to multiple points around the state and they want to know which ones to route for effective planning and minimize fuel consumption. Marketing and advertising, like we said before, personalized advertising content. In terms of education, personalized learning experiences. This certainly is becoming more prevalent at this point in time, and certainly in the near future. And energy companies use AI to predict demand because they can't scale immediately. They have to plan ahead for when they need the demand. So it's very important in the energy industry. And cybersecurity, AI is used to detect network intrusion and resource utilization. For example, one of the hallmarks of managing IT resources is to understand underutilized resources and resources that should not be used by a particular user login. Okay, next slide. So now the promise of AI inside of healthcare. Medical imaging, we're familiar with that. Interestingly enough, medical imaging is very sort of complex, but AI has the ability to look through thousands and thousands of images where the images had been previously read and classified by one or more professionals. Then the AI kind of learns that based on the thousands and tens and thousands of images and interpretations, it learns how to interpret images, and it does so in a rather strikingly brilliant fashion in terms of accuracy. So those things are coming online. Drug discovery and development, AI is used to try to figure out how molecules position themselves to bind with other molecules such as proteins and so forth. And that's key. And certainly with respect to the COVID virus, very complex molecular structure, and that protein had to bind, or the antigen and the spike protein had to bind, so forth. So AI is used to develop molecular structures. Personalized medicine, as I mentioned before, medical history now, patient's genetic information, their lifestyle information, social, predictors of health, the social determinants of health are becoming more important because now we can handle more types and diverse types of data to manage patients' health. Medical chatbots are becoming more popular and online, certainly in the future, if not now, but they're coming online quickly. Population health. I did work in the insurance industry for some time in terms of analytics, and even today, the markers of good management for population health are predicated upon guidelines and established rules and clinical limitations. If you don't, you have to see your physician every 6 months. If you have a chronic disease or diabetes, for example, you have to have your A1C under 100 or whatever the limit is, or your glucose A1C under 5.7 or 5.8. But those are guidelines, and so population health is not about painting the population with the same brush. Everyone has to be under 5.8 or 6 for A1C to be healthy. It depends really on a lot of factors, and so as AI is applied to the population and personalized medicine, we'll find that the A1C value probably is going to be optimized depending on the individual, the limit that you can tolerate. Cybersecurity, again, like I mentioned before, even in healthcare, hospitals are vulnerable because of the amount of, the value of the data is extremely high, extremely sensitive. That's part of why the value is high, but also the network in a hospital system is highly distributed, and because of that, it's quite at risk. Electronic health records increasingly using AI to identify higher risk patients and so forth. Historically, it's been a rule-based type of detection, but as AI becomes more prevalent in electronic records, it will go beyond being rule-based and more personalized for what the limit should be for that particular individual. Okay, next slide.
I'll take this one, Michael.
All right.
Okay, so as you can see here, there's a list of different uses as it would apply to folks in your setting, more in the rural setting. And you see a lot of similarities to what Michael just spoke about. And again, without going through each one of them, you'll see again at the end, the cybersecurity, population health, the disease prediction and surveillance, et cetera, et cetera. So there's a lot of similarities as how healthcare in general and providers in general can utilize AI. A couple that we're going to go through would be related to some population health, and one that I'm about to go through quickly is the cybersecurity. But in all these cases, the key, as I mentioned in the beginning, is that the data exists and that you can dip your toe in the water. What I mean by that is you can take that data, run it through a tool or series of tools to find out the anomalies or the intricacies or connect the dots, as Michael was mentioning, within the data that will help you to be more efficient and effective. And all these things can be done, I'm not saying easily, but I think a lot easier than you may imagine, because the tools do exist, the data exists. It's just a matter of applying them and honing the tool to get to those connections of data, identifying anomalies, whether they're clinical or financial or both. So that's what all these different areas, again, in the rural setting, are tied to. And again, you can do all these areas for the most part in an affordable fashion because the data is out there, the tools do exist, and the firms such as ourselves can take those tools and adjust them to your particular use case. And again, you can take a use case and dip your toe in the water by simply doing it on a risk-free basis. So see what you can predict. If it's amenable to AI, then move forward with a project. And what I mean by that is don't pay up front, but rather get the data to a firm like us or somebody else, see what they can do with it, because we do have the tools at our disposal, and then come up with that use case based on that preliminary work that's being done. So now some of the applications and specific examples that we'd like to take you through. So obviously you can see, and I think I mentioned on the previous slide, anomaly detection. So that's, again, looking for unusual behavior or looking for rarities within the data, whether those are patterns, whether those are usual patterns, or whether they are complete unicorns. So it could be in a million rows of data and have 3 to 4 occurrences. And again, in a log file setting, as you'll see next, that's something that you should be looking for, and having those tools hopefully would provide you with more of an ability to go out and get cybersecurity or cyber liability insurance, which I know is a big risk for those of you out there in the rural setting and even in the urban setting. Some of the other areas that we'll go through would be risk profiling, population health, intervention, and then predictive analytics. And you can see there's a variety that we talked about on the first screen, with some being unsupervised learning and others being supervised learning. So in unsupervised learning, it's basically the machine doesn't know what to look for, but it evolves and identifies pattern based on the data. Supervised learning, there's a little bit more front-end work that's necessary, but again, having the right expertise can lend itself to looking at those particular areas of data and finding what you're looking for, which again, I hate to use this term, but I think it's appropriate, would be finding the needle in the haystack. So it's not that a human being can't find these things, it just take a lot more time and effort and multiple FTEs to find what you're looking for. Let me pause real quickly. Are there any questions out there thus far? Okay.
I don't see any questions yet.
Okay. Moving on to anomaly detection. And again, the thought here is we're going to give you at least a couple of examples, albeit in the way of PowerPoint slides, but it'll give you an idea of how anomaly detection can work. So this first anomaly detection example is tied to network access. So there's a log file that's generated by all your systems with folks that are part of your network that are accessing different systems, whether they're accessing it outside your network, being authenticated through the proper amounts of security, but having access to those internal systems. So the way that this is used is it's proactively monitoring IP addresses, MAC addresses. So basically people coming in from a computer or from a footprint, accessing those different systems. It provides it looks at the log files rather, that gathers all that data and looks for anomalies. So as an example, if somebody were to log into your network through multiple IP addresses at 3 o'clock in the morning, that should be an anomaly. Or somebody that's trying to access multiple systems that doesn't typically do that, meaning a specific user. And even if it's outside of the typical time zone or the time frame that they would access the system, that is also an anomaly. So what it provides somebody such as yourself is, I wouldn't say it's proactive, but it's more real time within 24 hours of somebody accessing the system. And that information then is provided to the security folks, the IT security folks or person, to be able to look into pinpointed areas of concern or potential concern. In many cases, it's not a problem, but at least you know somebody's monitoring your log files to look for suspicious or unusual activity. Again, based on time of day, based on multiple IP addresses, based on an unusual pattern by a specific doc or user. And what you see down below is the weighted scale. It's a little bit hard to read, but it also helps point you in a direction as to where to look or why it is an anomaly. And it gives you that weighted factors as to why a particular login attempt or a successful login attempt could be anomalous. So it provides people with the ability to go in and take a look at your system access and identify where there may be a problem in the way of an anomaly. So this one is a simpler example in a sense, but I still think it very relevant and a very effective use of AI, which would be system resource utilization. As I'm sure most of the folks on the phone have, there's multiple systems that your clinicians, your administrators, social workers, et cetera, access on a daily basis. And in many cases, there's a threshold as to how many seats or logins or seats to that system that you're provided. And if you go over that threshold, there may be a cost associated with the amount of users that you're paying for to access the system. So what this is an example of is just looking at these different systems and identifying folks that might be, in the sense here, we're saying underutilizing a system, or their login might not be necessary. So you might be able to cut down on the amount of users accessing specific systems. And one of the things I found interesting is you see over on the side, it talks about 4.5 logins was a threshold. I've been in meetings when I've been on the provider side, and we spend more time in cycles talking about what low utilization is. Is it 10 per month? Is it 2 per month? Well, the machine kind of figures that out for you, or not kind of, it does figure it out for you to give you a more scientific approach as to what utilization could be or low utilization would be. Again, not a huge use case here, but it is something to keep an eye on and make sure you're not paying for user or seat license that you don't necessarily have to pay for. Michael, you want to take the risk profiling section?
Sure. Okay, supervised learning really means the process by where we already know the outcomes of our process, and the machine will learn the process, the outcomes, and the factors that are determining the outcomes. So let's advance to the next slide, and we'll go through the first example of risk profiling. And that is related to the HCAHPS scoring problem, the Hospital Consumer Assessment of Healthcare Providers and Systems. And so the opportunity here is, as we may know, the hospital can get a bonus if, in fact, its customers enjoyed, if we could use that term, their experience in the hospital. And so the survey that is sent out after discharge to the patients has a number of questions on it. And depending on how the patient scores these questions or answers these questions is whether or not the hospital can be eligible for a bonus under Medicare. So the problem with this is that if we have some scores that are low, and I think it's marked sort of on a curve, is the way the think CMS is doing it. How do we get to the top of the curve? Well, the only way to do it is to sort of outsmart the system in terms of how do we get everyone to be satisfied, over the next hospital. And in order to get to everyone being satisfied, we have to understand what the difference is between those patients that are satisfied and those patients that are less satisfied. And so one way to do that is to collect the data during their encounter in the hospital, and examples of it's very hard to read, but okay, what language do they speak? What shifts did they have associated with their stay? The types of admissions, the discharge type, whether it was to a nursing facility or went to home or long-term care, what service lines they were involved in the hospital stay, their age bracket, what unit did they stay in, and so forth, and even things like the nursing staff. These are all part of potential, not necessary, but potentially impactful factors on the patient's comfort and experience in the hospital. And there's probably many more. Some we can have access to or understand, and some are hidden and we just don't know. But to the ones we know, and that is, the discharge type and the patient's language and their age group and what unit they stayed in, and the service lines and so forth, we know that. We even know the clinicians that they experienced. And so if we feed that into a computer plus the score, and on the right-hand side, if it's hard to see, we basically had a binary score. Even though there's different categories of the score, the ones that count in terms of moving ahead in the curve is whether or not the patient always experienced a good outcome versus sometimes or less than sometimes or never. We want to know if they always did. So, so as you can see, this is complex data. It's sort of categorical, but it can have many columns. And for us humans, it's kind of complex to look through this and make any sense out of it. And often there's no silver bullet, like, okay, there's one thing or one healthcare provider or one service line or one area in the hospital where everyone says I had a great time and everyone else in different areas of the hospital did not. It's not that simple. It's multifactorial. So artificial intelligence can find some predictors here. Let's go to the next slide. And in this slide, we basically, after supervised learning and understanding as a byproduct of the learning process, that is, we distinguish those patients that elected to say they always experienced a great experience versus those that are elected to say never or sometimes, for example. We now have a difference. And in this example, it shows on the right-hand side that the high impact for a negative outcome are those patients that stayed in Unit 2E and 1E, and those that spoke Spanish, meaning there might have been a language gap in going on here as well. And we also see the other side of the coin where those that had the best experience, in this case, had a service line of medical or obstetrics and the patient unit and the patient age group. So we can see sort of, okay, if we wanted to take some action and improve these scores, what we could do. We could, instead of, let's say, meeting with the entire hospital group or all service lines at once, we could target our intervention. Okay, this service line needs to have better communication with patients, or this hospital unit seems to be always coming out red, so maybe there has to be something going on there in terms of communication skills or other activities. So this can this opportunity can point an intervention where you normally would have rule-based sort of quality process factors. We can now target and prescribe some interventions here to improve scores. Next slide.
I think this is mine, Michael.
Okay.
So on the risk profiling side, and again, this is supervised learning. So this is a real world example, and it involves a mental health facility. So I'll get into that. So again, it was a behavioral health addiction treatment organization. Obviously, it did both, and they were struggling with folks leaving the treatment center without completing their treatment. And why that was important, or why that was a problem, is because the treatment in many cases was front loaded. So you had the nursing consults, in cases you had H&Ps, any intake information, the psychiatrist was meeting with them, et cetera, social work. So if somebody came in and left, let's say within the 3 to 4 or 5 day range, as opposed to staying the full 3-week stay, you had the cost of an unoccupied bed. And also, as it says there below, the clinical treatment was front loaded. So you didn't have the benefit of receiving the revenue over a 21-day stay, but rather a 3 to 4 to possibly 5-day stay. So you're doing two things that weren't great. One of which is that the patient wasn't being treated completely and effectively. And number two, from a revenue perspective, you're upside down because you didn't get to recoup the costs that were associated with all that upfront clinical work and data intake that was associated with somebody's initial stay. So this is a comparison at what things were happening with regard to about a 25%, almost 26% people leaving without completing treatment. And with some real rudimentary AI work, which is basically identifying and profiling patients that were likely to leave before their before their treatment was completed, lowered it by almost, I don't know, like 8 percentage points there, which equates to about $2,000 per occurrence, and could increase revenue by about $17,000 to $18,000 per month. Again, these are roundabout numbers, but they are numbers that have an impact to the bottom line, especially for a smaller facility. So really, types of things that were identified in this case wasn't just profiling a patient that was likely to lead, but some of the interventions were more explanation of the complete process, meaning you might feel better after detox after 3 to 4 days, but you're not cured. And what we also found is a number of patients were leaving over the weekend. And the reason that was occurring is because there wasn't as many professionals available, clinical professionals available. So in many cases, there were volunteer stays for this detox unit, and they would leave because they felt better because the initial wave of that detox was past them, and they felt physically better, but yet they obviously haven't conquered that mental component, which is very important from a detox perspective. So just simple things like identifying the days of the week where people were more likely to leave, and providing certain very affordable interventions, meaning just have the group chats, having clinicians involved with them more over the weekend so that they don't leave. That's what really caused the needle to move in the way of these 9 cases per month, which isn't a ton when they had multitude of beds available, but it is enough to see a positive impact.
Yeah, so we were looking at the admission day of the week of admission. Remember, JR? So we found we weren't looking at the discharge day because people are discharged all week long normally. But what we did find was those that were admitted on Wednesday were likely to be
thank you, Michael, for clarifying that. Yeah,
leave
they
on
were
the
leaving
weekend.
over the weekends.
On the weekend, yeah.
Yep. All right, Michael, you're back up.
Sure. Okay, so now here's an example of unsupervised learning. So this is machine learning where we don't have the outcome. We don't know, we kind of know what outcome we're interested in, but we just don't have it. We're not able to measure it for one reason or another. So let's go into a population health intervention example. And in this particular case, we have we know some things about our patients. It could be through medical records or insurance claims or pharmacy records or health assessment forms. All of these can sort of contribute to the sort of patient profile. So looking at this, we have different patient on each row, and we have some documentation of medical conditions. So in an ideal world, this is sort of available for population management. Certainly, health insurers have a lot of this information, but we have coded information for chronic illnesses. We have coded information for behavioral health conditions to the extent we discover those, and more recently, social determinants of health are now more likely to be encoded in one form or another in some record. And so all three of those sort of play an important role in characterizing sort of an individual's health profile and future health profile. So when we look at the data here, we have sort of the ones that indicate the patient has it or not. DBT, let's say diabetes, depression is in there and so forth. Eating disorders and other behavioral health is in there. And you can imagine if we extend the number of columns off to the right, we could add social determinants of health to the extent we have that some of that data. But, you know, if we could know all those things, we could understand the resource demand by location better, meaning we know the patient identifiers, so we know where the patient's located in the state. And because we have a pattern, it kind of looks like an old player piano script, but we have these patterns of, let's say, ones and zeros. We've kind of boiled this down. And in the real world, it's not ones and zeros, but it might be codes and so forth. But we all turn it into ones and zeros. But we can have a long list of columns and so forth, and a lot of rows for the many patients. And what we'll do is we can cluster through this unsupervised learning patients that are similar, that have the most similar profile of ones and zeros. And as a result of that, we could understand the resource demand by the group of patients or a cluster. So let's move to the next slide, and I'll show you what I mean. This slide shows sort of the result of what we found, where the top section here of our table shows the sort of chronic conditions, ongoing conditions, and the bottom section shows what we learned about the behavioral health diagnoses. And the algorithm has found, let's say, 16 clusters or 16, 16, we could take a population, let's say 50,000 or whatever, and we boiled it down to 16 common patterns. It may be more, could be less. And we can control some of that with the algorithm tuning. But what this means is now we can sort of profile the population so that it's more personalized. It may not be individualized, but it's optimized for the cluster. So let's take cluster number 3, for example, and we look down from the top down, number 3, we see this is a group of people, in fact, 7,871, that have high prevalence for heart failure and COPD. Some have bipolar disorder, and another number, a large number, have a schizophrenia diagnosis. And, a lot of times we see this coupling between behavioral health issues and chronic disease. So, this is an opportunity to look at the holistic approach and not just treat the heart failure with medication or even, dietary recommendations, even though that's a classic example. But we also have some behavioral health issues that we may want to treat, because that could certainly complicate the medical treatment. And if we look over to column number 8, here's another sort of similar profile with OCD as a component, another group of patients where maybe OCD is contributing to the poor lifestyle or health habits, contributing to the heart failure and so forth. And so you'd want to sort of attend to the OCD in addition to treating the medical conditions. Substance abuse also can be a contributing factor. So this cluster of folks are likely to have these 4 sort of dominant traits. And you can see on the bar chart in the bottom right-hand corner, the weights of sort of the different types of findings in describing that unique cluster of patients. The interesting thing about clusterizing a population such as this is, if you have a patient that the machine says really fits best in the cluster number 8, but that patient has, let's say, they have no diagnosis for OCD or no diagnosis for substance abuse, but the patient does have a HF diagnosis or a COPD diagnosis. This tells someone that, boy, they should be assessed for OCD and substance abuse because they've been profiled to fit best in cluster number 8, meaning they're more likely to have an undiagnosed OCD or substance abuse condition, which helps target the at least the assessment in those areas. and expose potential risk factors for complications or unable to control the chronic diseases. So it promotes the targeting of risk management. Okay, predictive analytics. Let's go through this particular example. And in this particular example, we're going to look at the coronary calcium score as the indicator of the presence and extent of calcified plaque in coronary arteries. Now, this is a little different example because this is an example of sort of population management, but over time, and it just gives you sort of a different flavor of what could be done from a population over a period of time. So we used a research study data that's been publicly available to model future population risk based on available data, widely available data, and the desired outcome. And in this case, the desired outcome is if you have calcified plaque, the desired outcome is not to expand that score too much in the future, right? If we already have some heart disease, we don't want it to continue over time. And we want to know what factors help suppress that continuation of progressive coronary disease, which we all know catches up to us in our 60s, 70s, 80s, and beyond. So we're going to find out what this model tells us, who is most at risk and what factors contribute to this risk. And we want to profile the population risk factors, and we want to be able to intervene early with actionable changes. Okay, let's go look at the data. And so the data that was used in this particular study, and by the way, the study is publicly available, and the reference is in the bottom left-hand corner of this slide, and you'll be able to get copies of this. So you can look that up, and the data the study used is widely available, and it's several thousand patients that work for a Samsung in South Korea. That's a very well done study when you look at it. The type of data that was used are the types of data that's available, the duration of observation in years across a patient, and their BMI and their systolic, diastolic blood pressure, total cholesterol, and hemoglobin A1C, and so forth, their triglycerides and their HDLs, and smoking status and alcohol status, and what their baseline coronary calcium score is, and so forth. And so that data is sort of relatively available. And then we take this data, and the process is really time and lifestyle, right? And so we take that process, we get to measure this clinical data over time, and then we have the model learn, well, some patients seem to stop their score progression and others don't. And what is the difference among those patients? What can we learn about all this clinical data, and which stops the progression of the score, which we know is sort of an indicator of the magnitude of coronary disease. Let's go to the next slide and see what it says. So, when we run the machine learning through that data set, we can learn that the outcomes of data over time for those that have increased calcium score above, let's say, a certain amount, let's say their score went up 100 or more points. What are the factors attributing to that or associated with that change? And the data clearly points out, and the papers suggest this as well, but we ran independent machine learning on the data, separate from what the paper did, is that the single most significant predictor was your hemoglobin A1C status, which is sort of counterintuitive from the classical guideline that, well, the LDL-C, you want to keep your LDL-C as low as possible. In this particular example, and if you do additional research, there's a growing interest in managing blood glucose, not that the 100 milliliters per deciliter limit for prediabetes is a magic number, but that the lower limit is probably a smarter limit, certainly for certain people. And that the paper actually shows that there's sort of a linear relationship between the risk of calcium score progression and a normal range that is like a 5 to a 5.7 range of hemoglobin A1C. Very interesting finding, but you will only find it through sort of a machine learning, advanced analytics on the data over this period of time, observation time. So the strongest factors happen to be actionable through lifestyle. It's like the hemoglobin A1C. You can't do much about age, can't do much about gender, but we can do something about a hemoglobin A1C. That's lifestyle and diet and so forth, and certainly BMI. That's weight and systolic blood pressure. Okay, let's go on to the next slide.
So
Okay, JR.
hopefully we answered and got to the learning objectives and the agenda items that you see listed here. And again, what I would encourage all of you on the phone to do, if you haven't done it yet, is to dip your toe in the water with regard to the machine learning or AI pool. And again, do it in a way that's risk-free. So come up with a use case or collaboratively work with folks that understand about the tools and the tools' importance and how they can be deployed. Pick a use case, send a data set over with the appropriate amount of protections, whether it's an NDA or some kind of an agreement, and do that on a risk-free basis. So basically take that data, have somebody that's qualified, look at it, determine if there is a use case, meaning can you move the data clinically? Can you move it financially? Can you move it both? Whether it's security-based, et cetera, some of the other use cases that you've seen here. But again, my conclusion would be just take a data set, take a problem area within your health system or within your hospital, and try to see what can be done in the way of AI to effectively and again affordably. And in this case, it's completely free by just figuring out how you can utilize AI within your four walls or within your community to help the folks that you guys serve. And that would be by protecting your bottom lines and making what you do more effective and more efficient. Thanks for your time. And on the next slide, listed some of our contact information. Again, if you want to reach out to us, that's fine. And again, if you also want a copy of the presentation in PDF form, that would be great as well. Just let us know. Any questions at this point?
I haven't seen any come in.
Okay.
Well, thanks everybody for your time. If there are questions, again, our contact information here is feel free to reach out to us and ask us anything that comes to mind after the fact.
All righty. Well,
Yeah,
we
thanks.
appreciate your presentation. That was full of lots of information. Still no questions have come in. So I believe that means you covered your topic and objective perfectly. So thank you and have a great day.
Thank you, you too.
Thanks, everyone. Bye.
Bye.